My name is Mahant Malempati. I am a current second year student at Tulane University School of Medicine. I'm presenting a paper today called Stroke and COVID-19 Review Case Report Trends. This research was conducted with the Tulane Clinical Neuroscience Research Center, and there are no disclosures. So for today, our learning objectives are to understand mechanisms and etiologies of stroke, understand the inflammatory response to COVID-19, and understand the overlap between these two mechanisms that contribute to having COVID-19 and stroke occurring both in a patient, and understanding the impact of comorbidities on the pathways involved in both COVID-19 and stroke. So I like to, this question is just to get like a gist of like what the key takeaways are from this presentation. So based on the observations from this study, which group of events is most likely to be seen in a patient with COVID-19 and stroke? And these are the options below. It's presented in a manner where you see the chronology of disease first, what comorbidity they have a history of, what their gender is, and their age group. And so like a hint to answer this question is, this is not asking what is more predictive of stroke happening, only what you're more likely to see based on the data that's going to be presented. So moving on, let's start with our introduction. So we're just going to look at basic mechanisms of stroke and COVID-19. So severe infections of COVID-19 lead to higher incidence of stroke in patients. To understand how these two conditions are connected, we must first go through these mechanisms of each. Stroke is caused by mechanisms such as atherosclerosis, embolus, thrombus, vasospasm, hemorrhage, and reduced systemic pressure. These all represent the biophysical mechanisms of stroke. And inflammation on the right side, you see the table with inflammation, that also represents a contribution towards stroke. And these are chemical mediators that promote that pro-inflammatory phase. These mediators are called danger signals, and they're released in reaction to ischemia, mechanical injury, or infection. One such dangerous signal includes ATP, which acts on the P2X7 receptor that is also seen in graft versus host disease as a mediator. And there's also a high mobility group box 1 protein, HMGB1, that acts on TLR4, which is a toll-like receptor, which you also see in like bacterial infections, that causes immune cells to release cytokines as well. And finally, all these danger signals presented here, ATP, NAD, heat shock protein, HMGB1, they all act on the NLRP3 pathway, which activates an inflammasome, and that leads to secretion of cytokines that promote inflammation. And so this is all related to like stroke-related pathology. And then on the bottom left, we have the COVID-19 inflammatory cascade, and some of the mediators are released through that. And those includes the release of cytokines, monocytes, neutrophil excision traps, and it also, COVID-19 also activates complement, the renin-angiotensin system, and also causes endothelitis and DIC. So these are all like things that could contribute to the coagulopathy and inflammation as well. So moving on to our project, the methods for this project, we looked at individual case reports of patients who were hospitalized with COVID-19 and stroke using PubMed and Google Scholar. And we excluded systematic reviews from this search. When extracting the data, looked at age, gender, chronology of disease, NIHSS score, type of stroke, mortality, functional outcomes, and comorbidities listed. And then when organizing the data, the patients were divided into 3 distinct categories. They were called, the first one is called CIS, which is COVID-19 induced stroke, meaning the patient was hospitalized for COVID-19 and after more than 24 hours developed a stroke. Then we have STC, which is stroke then COVID, meaning the patient was hospitalized for a stroke and then more than after 24 hours, they tested PCR positive for COVID-19 or developed symptoms. And then finally, the last one was COVID-19 and stroke. Patient was hospitalized within 24 hours, had both conditions, and the chronology of stroke or COVID did not matter. It was just within 24-hour time frame. We divided this group. And then we looked at each category's characteristics based on age, mortality, comorbidities, gender, NIHSS score, and mortality. So moving on to our results, based on the division of these categories, the largest category actually was patients who had COVID-19 first and then presented with stroke more than 24 hours later. that was 55 patients out of our total 68 that we looked at. And then we had stroke, then COVID with 7 patients, and then stroke and COVID at the same time with only 6 patients. And then in terms of our gender breakdown, in general, like the general category stands for all 68 patients. Majority of our patients were male, 63%. And you can also see that for the COVID then stroke category. However, what was interesting here was for stroke then COVID, most of the patients were actually female. However, this is only 7 patients, so there would need to be like further research in like specifically in this category to see if that trend holds. If the majority of those patients are female, and that could be an interesting area of research. Moving on to mortality, the overall general mortality among all 68 patients was 47.69%. And mortality was lower for patients who had COVID first, then stroke. It was only 43%. And those other 2 categories were actually higher, where stroke was first or both were within 24 hours. So that's also something that could be explored in future research. And then finally, moving on to the age breakdown, we broke down the categories into young, middle, and old. Young was anyone under 49 and under, middle was 50 to 70, and then old was 70 and above. And 47% of our patients were in that middle category in general. And then that was followed by 33% being in the older category, and then 20% being in that younger category. And then moving on to comorbidities, hypertension. So I was just going to go run through like what our general data was for all 68 patients. Hypertension was the most common at 53%. Then it was followed by diabetes at 33%, and followed by atrial fibrillation at 10%. 6% of our patients were smokers, and then 6% had kidney failure, and 3% were diagnosed with cancer at the time of stroke. And then moving on to the final discussion, just talking about the prevalence of stroke in the United States. In the AHA report on heart disease and stroke statistics, the annual estimate for prevalence of stroke was more than 795,000 people in the United States, with 610,000 being first or new strokes. And then moving on to the worldwide economic and social burden of stroke, in 2017, there were 24.1 million stroke cases. This led to 15.7 million additional disability adjusted life years and 700,000 more stroke-related deaths compared to the 2016 data. And then looking at current issues with COVID-19 at the time of this study being written, the most recent WHO report showed that global cases were stable between the weeks of September 12 to 18. There were 3.2 million new cases reported and 9,800 deaths. And the most prevalent variant was a descendant of the Omicron variant, BA.5, which was 76.6% of global prevalence. And next up was BA.4X, which was 7.5% of prevalence. And then finally, these 2 diagrams here are just going to bring the initial discussion together, bringing the COVID mechanisms and the stroke mechanisms together. So the first pathway you see is the NLRP3 pathway, which was discussed as something that was contributing towards stroke. And as you can see, these inflammatory cytokines released by this pathway, seen both in COVID and stroke, contributes to plaque instability. Macrophages, which release proteases, can damage the extracellular matrix. There's LOX1, which that along with reactive oxygen species can lead to stenosis and restenosis. There were the neutrophil excision traps, which were mentioned earlier, and those actually contribute towards the formation of microthrombi. And then there's a disruption in the balance between coagulation and fibrinolysis. So there could be like increased D-dimer, fibrinogen, there's heparin resistance, and the other side of things, there's decreased protein C, protein S, and antithrombin seen both in stroke and COVID when they were seen in conjunction. And then finally, looking at the comorbidities, COVID-19 enters through ACE2 receptors in the lungs. And so in patients with hypertension and diabetes, in general, there has been shown there is increased ACE2 expression. This could suggest that there's more severity of disease of COVID-19 in these patients for that reason. And other possibilities for diabetes as well as there's increased furin, there's impaired T cell function, increased IL-6. So that contributes to more inflammation, more severe COVID-19 infection, and, more likelihood of developing stroke afterwards. And moving back to the question, based on the observations from the study, which group of events is most likely to be seen in a patient with COVID-19 and stroke? Admission for COVID-19, followed by a stroke a few days later, history of hypertension, male, 52 years old. So this kind of brings together that picture that COVID-19 induces an inflammatory cascade that leads to hypercoagulability and increases risk for stroke. And then also factors in how hypertension can also contribute to this. Hypercoagulability as well. And then our patient is male, which most of our patients when we looked at our cases were male, and he is within the middle age range category, which is 50 to 70. Thank you for your time. Please let me know if you have any questions.
Did you see any literature on whether hospitalized COVID-19 patients need any more prophylaxis versus just any other type of hospitalized patient?
There was nothing in particular I saw. We were actually talking about like doing a follow-up to this, looking at like the impact of vaccines on like this data, seeing if that's enough of a prophylactic measure to change these trends. The biggest issue was when I was looking through these papers, most of them were from 2020, or early 2021. So like before widespread vaccine use, I think that could be a possible avenue you could look into as like a prophylactic measure, but also like medications, like there was like remdesivir and all those as well. So, but there was no discussion looking any of the patient papers or case reports I looked through of any prophylactic measures really. So we excluded hemorrhagic from this. That was one of the actually exclusion criteria. So we only looked at ischemic stroke. Well, thank you, everyone.
Thank you.